cumulative damage that occurred after attacks and recurrent attacks, as well as the potential way for us to utilize a certain type of treatment, but be aware of the potential risk for ocular hypertension and glaucoma. My disclosures listed here in the slide for the various work that we have been involved in. So in managing ocular inflammatory disease and uveitis, one needs to be aware of the concept of cumulative damage in uveitis. In most forms of uveitis, the visual morbidity usually does not occur from just a single episode of uveitis. Rather, recurrent episodes of inflammation can cause excessive cumulative damage. The first time a patient has an attack of uveitis, one treated and the visual acuity often will return to 20/20s. However, after multiple episodes and treatment, at one notice, the visual acuity, for example, continued to drop slowly, 2025, 2032, 2040, and so on. So that's what we have seen in our clinical care. Some of the questions remain, however, or how many episodes must recur before cumulative damage occurred, and what is the minimum duration of each recurrent episode? This fourth figure represents what an eye can look like in the various types of cumulative damage that occurred. In the upper left, that is the case of lupus-associated chorioretinopathy after meningeal attack. In the upper right-hand corner, that's what an optic nerve and the vessel look like with many attacks in ocular Behçet disease. In the lower left is the case of sarcoidosis that have had multiple recurrent attacks. And in the lower right, the big audible inflammation there, that represents a case of granulomatosis with polyangiitis aspect from there. So each of these four clinical scenarios show to us what happened when we let recurrent inflammation occur one episode after another. Multiple studies have also indicated to us that there are prognosticators for visual outcome in uveitis. Certainly a delay in presentation to a subspecialist, the total duration of uveitis, the presence of intermediate or posterior uveitis or panuveitis, the number of recurrent episodes of inflammation, development of cystoid macular edema, which is the theme of these meetings, development of glaucoma. So how do we define this? As a way, I thought that Fallon Sensen well described this. The total insult incurred, which may be greater than the sum of individual insults as a result of repeated inflammatory attack on tissues, organs, or other body structure that often lead to irreversible consequences. When we look at the inflammation, just as in the movie, we can look at the good, the bad, and the ugly aspect of this. First, our tissue, the normal tissue homeostasis is quite strong and is maintained by the resident macrophage. With attack of inflammation, we see potentially tissue-damaging macrophages that functionality is too initiated due to the damage, the infection, and the autoimmunity. That's when inflammation occurs. And then followed with that, you have failure to downregulate the initial response that then results in the chronic pathogenesis and tissue damage. And of course, this is where we may not be able to get reverse stage. Eventually, the healing occurs, but by that time, a lot of the tissue have already damaged, leading to functional disability. This is a simplest curve, but it illustrates the point very clearly. The red curve, the sinusoidal, is representing the inflammation, or rather the recurrent episode of inflammation. The cumulative damage is the blue curve. So as one can see, with multiple events of inflammation, the red curve go up and down with attack, control, attack, control. Every time just recurrent attack occurred, the cumulative damage continued to rise. So eventually you will have a significant amount of cumulative damage that occurred. It's certainly, the damage can be quite devastating consequence of posterior uveitis. This is a case of the patient that initially presented to me with this type of picture in the upper left of a case of ocular sarcoids, as you can see, with some granuloma, some vitreous cells. The patient was advised of the certain treatment program. However, because of various reasons, the patient did not return to the clinic and was treated locally by the local physicians with various type of local therapy. And then he returned about 18 months later with this type of inflammation of the eye in the lower right, where at this time you have significance of the damage to the retina and the choroid, and suddenly leading to impaired vision. As clinician and clinician scientists, we definitely do not want to see this pathway. We want to keep our patient and their vision and their eye as in the upper left and not in the lower right image where damage has already led to significant loss of vision. Chronic inflammation is associated with ocular damage and posterior uveitis, and this has been shown to a number of aspects. Certainly, the topic for today's symposium, development of cystoid macular edema and uveitis, is definitely one of the reasons. Development of neovascularization in the pediatrics intermediate uveitis, and development of neovascularization, whether retinal or choroidal, cataract formation, and retinal detachment. These are all the potential damage that can occur with chronic inflammation. You have heard Dr. Igor just mention about some potential treatment, and one of which is with the fluocinolone acetonide insert, the 0.2 microgram per day under the trade name of Iluvien. This particular type of steroid has been demonstrated already to work quite successfully in another product called the retisert, which is also a type of device, but instead of an insert in the office, it's rather an implant in which surgical intervention is needed, with its subsequent risk of significant increase in intraocular pressure, which we'll discuss. So that now one can think of Iluvien or the fluocinolone acetonide inserts as the newest generation of steroid device that can deliver with very stable molecule, long-acting efficacy with strong anti-inflammatory activities, and is also the release for up to 36 months of that in this aspect. Certainly right now, the fluocinolone acetonide insert under the name of Iluvien is indicated for the prevention of relapses in recurrent non-infectious uveitis affecting the posterior segment of the eye, including uveitic macular edema. There have been several studies to illustrate the potential role of the fluocinolone acetonide insert. One particular one is the O1 study. In this study, there was a significantly fewer recurrence within 36 months, whereby the insert has 1.7 recurrences versus in the control that have over 5.3 recurrences. There's also a much longer time to recurrence, 657 days for eyes that had the inserts compared to 70 days for those in the control group. In addition, there were less adjunctive treatment and a much larger improvement in best corrected visual acuity. There was also a lower rate of intraocular pressure lowering surgery and the rate of cataract surgery in the inserts group. So those are some of the brief data. What are the lessons that we have learned from clinical practice using this fluocinolone acetonide insert with the release of 0.2 microgram per day of the steroid? There are some key learning points. First of all, patient selection is extremely critical. In that is, we want to make sure that these are usually cases of chronic sight-threatening posterior segment uveitis that usually associated with intermediate, posterior, or panuveitis. Unilateral or asymmetric disease are usually good candidate for this particular device. The ocular disease should drive the treatment decision. I repeat, in this type of patient, the ocular disease should drive the treatment decision. In other words, let's say a patient has sarcoid and the patient has been quiet in terms of systemic therapy, and right now it is only the ocular disease that is the dominant factor, then yes, the use of the acetonide insert would be a wonderful choice. On the other hand, if the patient still have active pulmonary disease or dermatologic disease from the sarcoid and still requires significant amount of the systemic treatment, one cannot expect just to use the fluocinolone acetonide insert to control the whole disease for this aspect. Other consideration would be disease responsive to steroids and compliant, very important, compliance with follow-up, which is aspect from there. Some benefits that occurred has been the sustained control of ocular inflammation that can be up to 36 months, the avoidance of cumulative damage from repeat cycle of inflammation. In other words, our goal in placing one of the steroid device in the eye so that there will be very stable chronic control of any inflammation so that you would not have that sawtooth pattern going up and down and therefore preventing cumulative damage from occurring. In addition, there's reduced need for adjunctive treatment and minimal systemic side effect from that aspect. So one can discuss with the patient and discussing the voice of using systemic therapy, including hepatotoxicity, renal toxicity, and then discuss some of the potential side effects of the treatment with the implant or the insert to see which one would be most appropriate for the patient. There's some disadvantage with this fluocinolone acetonide insert. That is, there's risk of cataract, there's risk of ocular hypertension and glaucoma, and again, after 2.5 to 3 years, if the disease is still active, one may still need to provide or place another insert in the eye. What exactly are we can consider in our clinical daily practice of this? So let's look at some practical consideration. When we talk about putting steroid in the eyes, all of us on this symposium and throughout the world, one of the first concern we have is that what happened to the intraocular pressure? After all, that is the most important concern that we have managing patients using steroids. Cataract, we can correct, although inconvenient, but we certainly can correct. But ocular hypertension and glaucoma is something that we're very concerned. So fortunately, the data from the 001 study is quite strong. And this graph showed you the mean intraocular pressure through 36 months having the fluocinolone acetonide insert inside the eye. The black curve at top, that represents the subject who were randomized to the insert, and the orange curve is the randomized with the control. And as you can see, the pressure very little throughout, and it did not go up more than about 16 or so in that throughout the 36 months of this regard. So the mean IOP by visit throughout the study was quite important and illustrate that the pressure concern was not significant at all when we put in it. Again, the patient need to have follow-up and make sure that is stable, but so far data have shown that the intraocular pressure has remained relatively stable when we place one of the fluocinolone acetonide inserts. So what are some of the appropriate cases for long-acting steroid implant and inserting here? First, the disease expect to recur or persist for more than 2 years. If you just have a case, or if we just have a case of unilateral anterior uveitis that we expect to be controlled shortly, that definitely would not be a good candidate for this steroid insert. So therefore, the disease should be expected to recur or persist for more than 2 years. It should be the ocular disease that drives the treatment decision, not the systemic disease. A third consideration would be intolerance of or non-responsive to standard therapy. And the fourth would be certainly sight-threatening disease that therefore give us the indication to consider it. Other appropriate situation would be no previous intraocular pressure elevation to steroid, or be prepared to manage the ocular hypertension very well, including to have glaucoma surgery. The subject, at least definitely, should have no severe glaucomatous nerve damage, so that, especially if the patient is monocular. And the third aspect would be that the subject, very importantly, need to comply with follow-up even when the uveitis is quiet. And that's very important to emphasize to our patient with that aspect. What are some of the inappropriate cases for long-acting steroid device, such as the fluocinolone acetonide insert? First, obviously, cases of infectious uveitis should not be considered. Cases of masquerade with an underlying malignancy, for example, should not be considered. Cases in which ocular disease does not drive the treatment decision, that should not be considered. And that if the patient has been non-compliant and you say, well, since you've been non-compliant, I'm just going to put an implant on you to make sure that it's under control. That is a bad decision, because if the patient doesn't come back for his or her regular checkup, you may have an eye that have rise in intraocular pressure, and then you will lose vision from that. So for this part of talk, the choosing the appropriate treatment option in here. Again, acute disease does not require long-lasting treatment, just as the fluocinolone acetonide insert. On the other hand, chronic recurrent disease should not be treated with repeat short-acting like intravitreal triamcinolone, for example, that keep leading to recurrent episodes of the disease, which lead to cumulative damage. So that's certainly an important factor. Now, I'm going to move to the next part, final part here, and discuss a little bit aspect about managing the ocular hypertension and glaucoma in uveitis patient receiving steroid device. Because as I mentioned, after all, this would have been the only type of any potential concern when one consider the use of a steroid, intraocular steroid device or implant in patient with uveitis. So some of this data has been helpful when we look back at some of the old data. As I mentioned, the retisert also contains fluocinolone acetonide in that, but it's about 3 times the molar of the amount of milligram of steroid compared to the Iluvien, which is the insert. The retisert requires a surgical procedure to place the implant, but a lot of that, the study that we look at right now in terms of intraocular pressure, we are very fortunate to have the data from the retisert to help us drive. For example, data from study revealed that intraocular pressure elevations occurred in approximately 65 to 75% of eye that have had the retisert implant. So that's definitely a lot higher than what we see right now with the Iluvien. 50% of implanted eye reach at least an IOP of 30 by 3 years. Again, that is not what we're seeing right now with the Iluvien. We see a much, much lower rate. At least 70% of implant eye require the IOP lowering medication within 3 years, and 30 to 35% of implanted eye require glaucoma surgery. Again, this is the number for the retisert, and fortunately, now with the Iluvien, we see a much, much lower number, and our patients are not at the same level of risk. Beyond having the steroid inside the eye, when we manage our patient with uveitis, all of us recognize that the patient, regardless whether they have steroid or not, can also be at risk for intraocular pressure elevation. So this is the fellow eye that result in the retisert study. That fellow eye did not receive the retisert, but again, 25 to 20% of the fellow eye developed IOP of higher than 10 mmHg over 3 years. 36% require IOP lowering medication, and 2% require glaucoma surgery. So one can think of this as very much like the baseline risk of eye with uveitis, regardless of whether the eye has or have not received any type of steroid device. IOP elevation in uveitis range from anywhere between 11 to 46%, and this comes from one of the earliest study that came out in 2004 with the number, I say 34% of the patient with chronic uveitis has IOP elevation requiring treatment. Subsequently, in 2009, another paper came out and showed that 90% of eye with IOP elevation from uveitis need treatment from this aspect from there. So again, this illustrates to us that regardless of what we do, eyes with uveitis are at risk for developing ocular hypertension and glaucoma. Hence, the term uveitic glaucoma also occurred. So, just data, what can they help us? What does this mean for a potential patient with intraocular steroid implant or insert. What should we do as clinician scientists to be able to manage this patient? Well, first, this data help to explain the risk of the fluocinolone acetonide insert, the ILUVIEN, or the implant, the retisert. They also help to explain the high risk of elevated intraocular pressure in patients with uveitis, and that the risk of visual loss is still real from glaucoma, and therefore we require close management. Certainly, such risks are much higher with the retisert than with the ILUVIEN that we are currently considering. What do we do, or what should we consider in patients prior to us putting in the fluocinolone acetonide insert in the office? First of all, we should have good documentation of the intraocular pressure coupled to this ratio. We should definitely obtain the color disc photo and possibly a baseline visual field as well. And we should also evaluate other potential causes of glaucoma, such as chronic angle closure from the syncytiae that occur from chronic uveitis. In patients with history of steroid response or diagnosis of glaucoma, perhaps we should also get our patient to see a glaucoma specialist before we put in one of the fluocinolone acetonide insert. The optic nerve imaging and pachymetry using OCT device and other devices should be obtained or may be obtained in those patients with ocular hypertension, elevated cup to this ratio in glaucoma. Again, the goal for us as the caring physician for patients is that we do not want to treat one disease for another, and therefore we want to provide our patient with the maximum care looking at multiple aspects. In addition, we should have a very thorough discussion with the patient about the need for regular intraocular pressure monitoring, even after 1.5 or 2 years after implantation. So please do not forget about the patient and the patient return for follow-up. Discussion with patient about the risk of vision loss if IOP elevation is left untreated, and coordination of care with local ophthalmologists if the patient lives far away and cannot come back to a major eye center regularly. Finally, for the post-placement patient with fluocinolone acetonide insert, what do we do once we put the insert already inside the eye? So certainly we should have regular IOP monitoring, either do it ourselves or have one of our colleagues help locally if necessary. We should have aggressively treat the ocular pressure elevation, especially in high-risk patients. Our study have shown that 50% of patients who receive the retisert would be on IOP lowering within 6 to 12 months. Definitely, we should keep that in mind, but also understanding that the study with the ILUVIEN thus far demonstrate a much better safety profile than what we have seen with the retisert. The IOP elevation may still occur 2 to 3 years after the steroid device, and so therefore, as a last sentence, please do not forget about this patient and the intraocular pressure, because we want to save the vision from uveitis and also from any potential problem with ocular hypertension and glaucoma. And with that, I thank you for your attention. And again, a sincere appreciation to Dr. Nurad and the Emirates Society of Ophthalmology, Dr. Hassan and Dr. Igor for having me involved with this across the oceans. Thank you.
Thank you so much, Doctor. We are honored to have you this evening in our time. And thank you for talking and explaining the implants in depth and the side effects and how to manage it. With our next speaker is Dr. Hassan Adibi. And just to remind all the audience that we are willing to...
We cannot hear you, Dr. Noura. We cannot hear you.
Can you hear me right now?
Yes.
Yeah.
Now
okay.
We can.
So thank you so much, Professor Kwan, regarding tackling all the intravitreal implants and talking the types of it in depth, and even tackling the management of raising intraocular pressure. And reminding all the audience that the questions we are happy to answer just in coming a few minutes after Dr. Hassan's talk. If you have any question, you can write it in the Q&A box.